Thank you so much, ma'am, and thank you, AIOS and Yossi, for the platform. So the session was about the extraordinary resident, but the two cruel waves of COVID affected most of my residency and most of the residency of a lot of people. And these are my perspectives and the perspective of any resident going forward after two waves and how they can make the most of residency, as well as how not all is lost. There is something to salvage from both the waves of COVID as well. So sometimes the goals of a resident are not exactly clear, but I went on to the NMC guidelines, and these are the quote unquote statements mentioned by the NMC as what a resident should ultimately achieve after 3 years. They are the following. A resident must be well versed in clinical and investigative modalities. He must have individually performed as well as managed complications of lid surgeries and other superficial surgeries. He must be competent in cataract surgeries, and he must have a desirable knowledge to perform intraocular surgeries other than cataract, like retina as well as glaucoma surgery. Now, turning back the clock, we all know that the COVID wave has now loomed upon us for about 2 years. There was one wave in 2020, followed by a second wave in 2021. The second wave sort of waned in September 2021, and there was a small third wave as well as COVID variants in 2022. So we are looking at a period of almost 2 years of residency training loss. Having said that, there are some perspectives of a resident going forward, and for the purpose of making it a slightly more simple, I will be dividing it into a clinical and surgical, an academic, a research, and a psychosocial perspective. So patient care during the entire COVID-19 pandemic dipped immensely, both for clinics, OPD, specialty clinics, as well as surgeries. A retrospective study that was done between the periods of 2020, comparing it between the periods of 2019, actually showed a reduction of 97% of OPD outflow, as well as emergency services decreased by 35%. Coming to the surgical aspect of it, we all know for a resident to hone their skills, ultimately it is the state-sponsored camps that they get cases from. The DBCS or the NPCB target for every year is about 66 lakhs. And though the data for 2020 and 2021 is not out yet, you can see that the 2019, 2018, and 2017 data is more or less meeting with the target. It is well assured that the 2020 and the 2021 data will be much less, which means that residents have got a really lack of surgical skills going forward. In fact, Dr. Akshay Nair et al. Conducted an online survey where he saw that residents are deeply impacted by the decreased surgical training as high as 80.7%. So these are some photos of what I was doing during my residency instead of being in the OPD or as well as the OT room. These are photos of lid suturing done by PPE. The photos are they're not purposely hazy. In fact, they are hazy because this is the exact view that you get while you're screening a patient. This is some photos from the second wave of COVID when we had to screen for CRAO in cases of mucormycosis. In fact, the photo on the right has been published in IJO as well, which I will come to a little later. These are some more photos of where I was in my second year of residency instead of the off-health clinics. The photo on the right is someone exclaiming at the admission of one more patient into the COVID wards in the middle of the night. So there's been a lot that has been lost in 2 years, but it's not fully lost. In fact, there have been some mitigative measures as well. Two of the primary mitigative measures that maybe can be taken forward is wet lab training, as well as the changing paradigm of resident teaching. Wet labs have a huge advantage because they help you hone your skills and also protect patient safety. There have been a lot of innovations in the wet lab as well in this regard. The changing paradigm of OSCE teaching has actually allowed consultants, professors to vary their teaching among residents. For example, you are only stuck with a couple of cases which you end up knowing the night before your final exams. But OSCE goes for a more comprehensive knowledge taken from the resident. Having said that, we come to an academic perspective where academic classes or patient exposure or bedside teaching or clinical teaching has been extremely hampered, but there has been an exponential rise of online classes, which has actually augmented postgraduate teaching. So the photo on the right shows me actually eating an apple and attending an Arvind seminar, which I believe would be impossible in a real life scenario. So as the photo states, you can eliminate the cost of travel, you can eliminate the time and place, and actually cater your learning and taper your learning to your convenience, which is actually an advantage for residents in going into these couple of 2 years. Additionally, it's difficult for residents to attend every single conference, but from the comfort of their home and almost every conference going virtual for the past 2 years, this has been made quite easy. So this is me attending an Ask Yossi panel 2 years back. As you can see, the who's who of ophthalmology is on this screen. And without the COVID-19 pandemic, I don't feel I would have stood a chance to share screen with them. This is from 2021's AIOC Yossi Forum. Another chance which I only got because of probably the COVID-19 pandemic and physical needs curtailed. Then we come to a research perspective. So a new disease obviously breeds scope for new research. In fact, Dr. Bharat Gundani sir wrote an article in the IGO mentioning how there was a rising trend of COVID-19 related articles as well. However, with this positive note, there has been a problem with dissertations because students and postgraduates are missing to meet their sample size for correction, as well as core fields of ophthalmology taking the sidelines. Research in the core fields of ophthalmology not done now might not seem like a big deal, but maybe 5 or 10 years from now will have an effect. In fact, through this COVID-19 pandemic, I myself got to test myself in the field of research. These are 2 articles that I published. We noted a case of bilateral retroorbital optic neuritis in a COVID-19 patient, as well as give my take on making the most of wet lab resources with a single microscope as well as single wet lab setup. Last but not least, we come to the psychosocial impact of COVID. So Dr. Khanna et al. Conducted a study in 2020 to assess the mental health among the residents and trainees during COVID-19 and found that there was 32% of them had some degree of depression. This is primarily attributed to the fear of a longer training period after residency because of inadequate exposure. Frontline work being not the domain of expertise for ophthalmology residents, us not being familiar with management of COVID patients, the fear of contracting the disease itself, it still looms quite high, as well as family constraints and financial constraints going forward. So 2 years have been lost. There's been a loss of clinical as well as surgical skill. There has been a boom of academics, but the loss of wet lab teaching. There has been a boom in research, but a stark effect on thesis completion as well as core fields of ophthalmology. Plus, there's always a looming threat of COVID. This has affected us for 2 years, but then there are some valuable additions that we can take forward. Firstly, the impact of COVID has affected all residents in the same way.
You have 1 minute remaining, sir.
Okay. It has opened new avenues for research. Online platforms eliminate the need for time and location, as well as eliminate resident-specific teaching. And finally, there are wet labs and simulators, which previously would play a second fiddle to patient care, are now taking primary importance. So there are some takeaways that we can go forward and make the most of what has been lost over the past 2 years. Thank you very much for your attention.
Thank you, Anujeet, I think, for that